So thank you very much for having me in Sydney today. My name is Edwina Wing Lun. I'm an interventional and general cardiologist from Darwin Hospital now, though I was trained at St Vincent's. And I'm presenting on behalf of my team, which includes some of these guys here. And I just thought I'd show you a little bit of the top end because it's kind of a bit like the Wild West and you don't really know what it is until you've actually been there. So this is Marcus, James and his wife Kira is a paediatric trainee. He's one of our cardiologists. And Waika is there, Dr. Chu, and also Hassam, one of our leading echo techs, also helped or do a lot of work with this presentation and also with rheumatic heart disease. Sorry. Is that better? Don't know. So just as a very brief introduction, the challenges of tricuspid pathology and rheumatic heart disease are manifold. So to start with, most rheumatic heart diseases occur in Aboriginal people. So 98% of all rheumatic diagnoses will be in what we call the blackfellas. Currently, 3,100 people living with acute rheumatic fever or rheumatic heart disease are in the Northern Territory. And that's actually about 40% of the rheumatic population. So that's almost half of our rheumatic population. And that is for 6 cardiologists, so representing about 1 to 2% of the cardiologist population. The numbers are probably increasing, and part of this is because of increasing pathology, but also because of our increasing screening and access to screening in remote communities. It's predicted that Australia-wide there will be almost 15,000 cases in 2031, and we'll get to a bit later, but that translates to at least 1,300 rheumatic tricuspid valves. So to illustrate rheumatic disease in the tricuspid valve, or of the right heart, I'll introduce a case of AC. So she's a very recent case of ours. So she's a 26-year-old female Aboriginal lady. She was care flighted just about a month ago from Meningreta with shortness of breath and a painful abdomen. Just so that you know what Meningreta is, because we'll keep referring to it. So this is Darwin, if you can see that there. It's quite a long way away in itself. And this is Meningreta, which is even more remote. This is the entirety of the township. This is the airfield, and this is the main street, which you can see here. It's about a 13-hour drive or just over an hour's flight. So the presenting complaint of AC is that of recurrent ascites and right heart failure. So this is not the first time we've met this lady. She's usually about 10 litres fluid overloaded from a baseline of about 50 kilograms. She has recurrent right heart failure due to her severe and torrential tricuspid regurgitation. She had mechanical mitral and aortic valve replacements in 2011 due to rheumatic heart disease. So she had mixed mitral stenosis with a mean gradient of 10 to 11 and moderate to severe MR. And she also had severe aortic stenosis with a mean gradient of 47 and moderate to severe aortic regurgitation. Her current medical management you can see on the right-hand side of the screen. And I will also show you, one thing I forgot to mention is that she's in persistent AF. She's been in atrial fibrillation since we first met her in 2010. She was not a smoker then, but she is now. So this is her current echo. She has 2 mechanical mitral valves, which are actually working pretty well overall. So being trained at St Vincent's, I go by Fenelly's law, and you can see that in general, sorry, it's just taking a while to reload again. You can see most pathology from this very first shot. So you can see that she's got a dilated left atrium. She's got a fairly good functioning LV. The valves look like they're not doing anything particularly dramatic, but the right ventricle has a suggestion that it's slightly bigger than you would expect on a normal person or a normal study. So in the drop shot, you look at the right ventricular inflow. You can see the anterior leaflet on the right-hand side, and it's either the septal or posterior leaflet, just depending on your tilt. And I thought that this was a very beautiful shot to show you what a rheumatic tricuspid valve actually looks like. So it's not something that I guess is explored particularly well. It's quite hard to find pictures and videos on the internet, but this one's real life. So the main things that you'll see here are that there's thickening of the leaflet tips, there's relative sparing of the mid-leaflets, and there is some thickening of the bases and some tight and slightly thickened chordae. Almost looks like the hockey sticking of a rheumatic mitral valve in some ways. I'm not sure why this isn't playing particularly well, but you get the impression that there's at least moderate tricuspid regurgitation. As we go through the rest of the echo, we can explore that further. So this is the parasternal short axis, and again there are some things glaring you in the face. So again, you can see relative to the aortic, albeit a mechanical aortic valve, you can see that there's a very large right atrium here, still quite large left atrium, and again the right side looks like it's dilated. Tilting just a little bit more anteriorly, you can see the tricuspid valve a little more clearly. And eventually we can see that this regurgitant jet is in fact severe. Don't know if I can play that any better for you. So it's got a pretty wide vena contracta. You can see that it's clear malcoaptation with torrential TR going through there. This is a still anyway, so this is the tricuspid regurgitant jet, which impressively doesn't show that there's a lot of pulmonary hypertension, so it only reaches about 24 millimetres of mercury. But you can see that it's very dense. It equals that of the forward flow, and it's quite triangular in its shape. In terms of looking at the parasternal short axis of the left ventricle, it's subtle, but you can see that there is this D-shaped flattening of the septum in diastole, indicating that there is fluid overload of the right side of the heart. And I'll just try and step through it a little bit. Might be that I've got too many videos. Hey, there you go. Thanks. All right. And so now it's away. Okay, this is a very similar shot, but you can see some of the subvalvular structures within the right heart there. So it sort of looks like there's a little bit of thickening of the chordae and even suggestion of a thicker walled RV. Okay, so onto the four-chamber. So again, some of the obvious things, so a really big right atrium there, a left ventricle, which is looking actually quite hyperdynamic, a right ventricle, which you get the suggestion that maybe the TAPSE wouldn't be quite normal, but it's not particularly well seen. You can see the moderator band, again, looks like it's a little bit thickened, suggestive again that there might be some pulmonary hypertension, but maybe we're just not recording it because of the torrential TR. And you can see that the subvalvular apparatus are more obvious than you would think that they would be, sort of around here. Again, you can see that the leaflet tips are quite thickened, and it's not quite as obvious in this view that there's malcoaptation, but just remember that you could see it on the previous views. So there's a close-up focusing on the right ventricle, making the malcoaptation a little more obvious. And again, that very impressive TR jet through that big wide open space. Okay. Subcostal, also another good view. And I was thinking during the previous presentations that it would be really lovely to have MRI or to have some of those more advanced echo techniques to be able to explore the right heart a bit more. But this is pretty much enough still if you interrogate the tricuspid valve well to see that there are in fact rheumatic changes. Anyway, I think you get the picture. So back to AC. So in summary, she's a 26-year-old female. She has recurrent ascites with right heart failure. She has, as we said, a mechanical and aortic and mitral valve, which are about 7 years old now, functioning quite well. She has severe and torrential tricuspid regurgitation, persistent atrial fibrillation. She's a smoker. Now, to just put it into context, she's otherwise like pretty much any other 26-year-old female. She's married. In other ways, she's not like every other 26-year-old female because she's isolated and she's now unable to have children due to her warfarinization and also because of her heart failure. Options. What do we want to do with this young woman? There's been a lot of debate. So do we do a reduced sternotomy on someone whose other mechanical valves are working quite well to do either a repair or replacement? And if we did go in, would we do a mechanical or would we do a bioprosthetic? Is there a minimally invasive option or a percutaneous option? Or do we just continue medical management? I guess realising that we're in quite a pickle here, we look back to see, was this predictable? Could we see this coming? Her first presentation in 2010, she was acutely unwell with shortness of breath and left ventricular failure due to her new onset of atrial fibrillation. At that time, she denied previous shortness of breath or orthopnea. She had a chest x-ray which showed that she had cardiomegaly already. She had elevated LFTs, and she was actually quite rapidly seen by a surgeon who, at that time, focused on her aortic and her mitral valve. Now, on the echo, it was noted that she had at least moderate TR and that her pulmonary pressures were only mildly elevated. But for some reason, this was not particularly taken much note of in terms of planning for her operation. This was her echo from that time, which is quite an impressive and quite typical, both rheumatic mitral valve and rheumatic aortic valve. And you can see that there's failure of coaptation of both of those valves. And they've got the typical leaflet tip thickening. At this time, you can see that she was actually quite unwell. She also had a pericardial effusion. Just for some comparison, if you can remember the previous four-chamber that I showed you, so her previous four-chamber, and you'll note that those tricuspid valve leaflets, it's subtle, but if you look there, you can still see that there's some thickening of those leaflet tips, making you think that there is something going on there. There is some organic disease affecting that valve. And if we look on toe, we can actually see a little more clearly. It's difficult to sort of compare the chamber size, but definitely that leaflet tip is sticking out much more obviously than it should. And if you, again, look at the regurgitation, she actually had severe tricuspid regurgitation at that time. Now, in the interest of time, I haven't gone through and included all of her echo images. Also, I think I broke this computer. So the story so far. So 2013, she had subtherapeutic INR, not uncommon for our remote patients, and that has a lot to do with difficulties in understanding what to do with medications and difficulty in accessing advice about problems with medications. And she had recurrent severe epistaxis and actually became quite anemic, which is why she self-ceased her warfarinization. At that time, she denied shortness of breath. In 2014, she had some decreased exercise tolerance because she was noticing that she was having some difficulty walking to the shop, and she had an increase in her abdominal girth, but she could not be pregnant. She was geared up for surgery because she was symptomatic at that time. However, by the time it came for close review, and keeping in mind sometimes it just takes a while to bring patients into Darwin, if they're not particularly or acutely unwell, by that time she said that she was asymptomatic. And so despite reassessment, she was for surgery if symptoms worsened or if she had echo features of RV compromise or dysfunction. By mid-2015, she again said that maybe she was breathless. As you can see that the symptomatology is a little confusing, but on examination, she was definitely in right heart failure. So to try and extrapolate this, and I think this is an important thing to note about our remote patients or our Aboriginal patients, or even those of just sort of a different language from our own, is that the way that they might express themselves or the way that they might document their symptoms are slightly different. So we have evidence. Exercise stress test for a 23-year-old lady at that time, she only did 7 minutes. In a 6-minute walk test, she only walked 300 metres and she desaturated to 89%. Again, she was suffering from recurrent epistaxis and she had had warfarin non-compliance, resulting in anemia, but also in a general consensus that maybe she wouldn't be compliant with further medication. And so again, a pullback to medical management rather than more aggressive management for her. Including surgery. 2017, she'd gotten used to just sitting and not really doing very much, so she wasn't particularly short of breath while she was doing that. And then until 2018, she had recurrent ascites. You can see her right heart study there actually shows that she hasn't yet developed pulmonary hypertension despite that TR. And given everything that she's been through, again, a decision to dry her out, try and keep her dry and keep reassessing her. So this is a bit of a funny picture. It's my daughter. And it's one of those things where I think with the tricuspid valve, we used to think that if you just close your eyes and fix the left side of the heart, maybe it would just disappear. But what we've found now is that when you open your eyes, it's still staring you right in the face. So severe tricuspid regurgitation, when we're talking about rheumatic heart disease, it fits into this little green category here and probably only about this much of the green category, so it's a very small portion of severe TR. But in the rheumatic population, is it really as rare as we think? In a fairly old study, 2003, 42 patients with rheumatic mitral valve disease were followed up about 8 years later, and they found that 71% had developed severe symptomatic tricuspid regurgitation. They found that after that diagnosis, 50% were dead within 3 years. All the mitral valves remained functional, so from, I guess, a surgical perspective, that seems like a success. The retrospective analysis of the transthoracic echoes showed that they all had dilated right atriums and right ventricles, giving you the hint that not all was well. And they had normal tricuspid valve leaflets. However, when they looked more closely at the toes and 3D reconstructions, they indeed could see that 100% had organic pathology. So I'm probably going to run out of time soon. Rheumatic tricuspid valve disease represents about somewhere between 7 to 9% of rheumatic patients. And it usually occurs, almost always, with mitral valve pathology. It's often ignored, as we said, because it is thought that once we fix the mitral valve, that the tricuspid valve will fix itself. However, we have little evidence about this, about what to do about it and how to explore it further and predict which ones will be fixed by themselves and which ones won't. What we do know about TR pathophysiology is that it's a self-perpetuating cycle, both from the ventricular side and also from the atrial side. So what do we do? There have been some thoughts about, can you just do tricuspid valve surgery alone? Can you do surgery with the other valve? So would you then, for her, wind up doing a triple valve? Would you do surgery later? Should it be repair, replacement, medical management, or are there other solutions? In terms of when you do surgery, the in-hospital mortality rate averages about 9%. It varies in some of the studies between about 7 and 15%, so that's within the first 30 days. Risk factors for it being worse or more likely to die in hospital are male, isolated tricuspid lesion, and post-clamping time, which probably represents more severe pathology within the heart rather than just the clamping time itself. Similarly, tricuspid valve replacement. The 30-year survival is pretty abysmal, so 12% will still be alive in 30 years, and you think that that means there's sort of 88% of these people, these 26-year-olds, that will be dead within 30 years, compared with 75% of everyone else who is still alive and have had normal lives with the option to have families and do many other things that they want to. Having said that, when they analysed those who had undergone surgery, only 40% had a satisfactory outcome with successful management of their severe TR. Rheumatic heart disease is something that is a disease of the young, so you can see peak age of diagnoses around 25 to 40. It's not going anywhere, so if anything, the incidence and diagnoses are going up. It's not cheap, so at the moment we're spending at least 27 million. And with the escalating numbers, as I was saying before, by 2031 we'll be spending 344 million. There are some that believe that if we invested at least 100 million into a vaccination program, that would be one way of stemming the issue. But of course, we will still have to deal with the ones that we have now. And I just thought I would show you very quickly that we had a second almost identical scenario, except she hasn't had surgery yet, actually in hospital at the exact same time. So anywhere you go in Darwin, really, or the Northern Territory, you can find lots of this disease to look at and to explore. And so that is pretty much it from me. Sorry, I think I've gone a little bit over time. So references. So thank you. And I'd just like to quote to finish off my, my esteemed colleague, James Marengu. Thank you for paying attention to the neglected valve of a neglected disease.